Good morning. Welcome to the COVID-19 Symposium at Hopkins. Navigating the pandemic when effective vaccines are in the policy toolbox. Not easy to follow Dr. Fauci, but certainly an honor and great to have him back at Hopkins delivering medicine grand rounds after his health policy forum visit in October. Thank you, Dr. Fauci. Truly an honor to have you with us. I'm Dan Polsky. I'd like to welcome you as director of the Hopkins Business of Health Initiative. It's our pleasure to be hosting the 2,000 plus registrants along with the viewers on the simulcast on our famous Hopkins coronavirus website. The Hopkins Business of Health Initiative has been launched to unite world-class experts in research, policy, and practice across Hopkins, Carey Business School, Bloomberg School of Public Health, the School of Nursing, and the School of Medicine to improve health by addressing national health care system challenges of affordability, access, equity, and value. Since May, we have been hosting interdisciplinary Zoom webinar series to advance evidence-based decision-making for COVID-19. Past events can be found on our website. We take on difficult and controversial topics and bring together experts who approach issues from different perspectives. We ask for all parties to engage in a civil discourse as we work towards solutions. In that spirit, we have an open chat and we will take questions throughout our two panels. The COVID-19 vaccine challenges our national healthcare system across these issues: affordability, access, equity, and value. We'll discuss many of these issues today as we push for evidence-based solutions. Now it's time for our first panel, barriers and strategies to achieving there we go. Barriers and strategies to achieving optimal COVID-19 vaccination rates. I'll turn it over to our moderator, Mario Masis, Professor of Economics, Carey Business School. Mario?
Thank you. Thank you very much, Dan. And good morning again to everyone. And thank you for joining us for this panel discussion today. Let me welcome and introduce our panelists. We're fortunate to have Alison Buttenheim, who's a professor at the University of Pennsylvania, and she's also the scientific director of the Center for Health Incentives and Behavioral Economics. Robert Litan, who's a non-resident senior fellow at the Brookings Institution in Washington, D.C. Dan Polsky, professor at the Bloomberg School of Public Health and in the Carey Business School at Hopkins, and also director of the Hopkins Business of Health Initiative. And Daniel Salmon, professor at the Bloomberg School of Public Health and director of the Institute for Vaccine Safety at Johns Hopkins University. We will begin with a first round in which we will hear from each of our panelists, and then we will have a discussion where the panelists can react to what the others have said. But of course, you know, we are here for the benefit of the audience, so we will also be selecting questions that members of the audience might want to ask. So as Dr. Fauci highlighted in his keynote earlier, even though we are still in the middle of this pandemic with cases and hospitalizations on the rise, particularly in the US. In the past few weeks, we received what he described as extraordinarily good news in that 2 vaccines for the coronavirus appear to be, according to the results that we have so far, very effective, more than 90% effective, in fact. So there are reasons to be optimistic that relatively soon we will have a vaccine that's safe and effective and ultimately also widely available. And this is the topic for today. So we'll be in a situation where a safe and effective vaccine is in the policy toolbox. And again, Dr. Fauci highlighted this, having a vaccine is not the same as having a vaccinated population. So we face challenges. Recent surveys of Americans indicate that about 50% of the population would either probably or definitely not take the vaccine. So there seems to be vaccine hesitancy, but also resistance to the vaccine. Of course, this is concerning because it can jeopardize the societal objective to achieve immunization for the population. So our panelists today will help us to understand these barriers to vaccine take-up and to think about possible solutions. So Professor Buttenheim, Alison, I'd like to start with you. What are the main barriers, the main reasons why some, and apparently a large share of Americans do not intend to be vaccinated, and what can we do about that?
Thanks, Mario, and thanks to Dan for hosting this amazing session. So yeah, I want to talk from sort of the behavioral science or behavioral economics toolkit. And I want to say up front, I think there's sometimes a thought that, we have some secret wizardry or special sauce that's going to, sort of fix everything. And we don't. But what we do have is a pretty great toolkit for kind of boosting or supercharging existing interventions. So when you hear us whinging on Twitter that, there's no behavioral scientist on, President Biden's coronavirus task force, it's not because we think we're super special. It's just we have a great toolkit with a great set of toys, and we want to play in the sandbox. So when we think about the barriers that folks are facing behaviorally to get this vaccine, I think of sort of three groups of people. And I think behavioral science is going to work really well for one of those groups and not so well for the other two. So the first group is luckily a really small group, kind of the hardcore anti-vax. And I don't love the anti-vax handle, but we'll use it because y'all know what I mean. Very small group. They have kind of an outsized voice and sort of amplification thanks to social media. But that's not a group that behavioral science or really any science is going to convince to get this vaccine. They've been on the front lines of, anti-masking protests and, protests against lockdowns and shutdowns. And I would not, with limited time and resources, spend a lot of time trying to kind of understand those barriers and get around them, certainly not with behavioral science. The second group is a group we know from other vaccine programs is kind of hesitant. They've maybe heard something from their cousin or have some concerns. And that's a group where, the vulnerability to misinformation is quite large. And I think Dan is going to talk about that later, so I won't go too much into that, but that's where kind of communication strategies, messaging, different ways of tackling sort of misinformation and building trust are going to be really important. I think we have to remember uniquely with this vaccine that there's some justified mistrust here, right? We have like this incredibly rapid development of the vaccine. We had a very politicized FDA approval process prior to the election. So there's some new challenges there with that hesitant group. And based on the survey data that Mario just talked about, that group is probably in the sort of 20 to 40% of the population. Sounds like interest in the vaccine is growing a little bit from that 50% number, but that's still a big chunk. The third group we think about as either kind of neutral or motivated to get the vaccine. And the barriers there are going to be, again, similar to things we know from flu vaccine or even from the childhood schedule or the adult schedule. There's just there's a big gap between intention and behavior. And a lot of that is stuff where the behavioral science toolkit is really, really helpful. So obviously, we want to make this as easy as possible for people to get vaccinated. We want this to be a zero friction, zero hassle, zero cost process. And even when we're managing sort of constrained supply at the beginning, we want to make sure people can get it everywhere, can not have to wait in line, not have to take time off of work. This should be at your work site, at your pharmacy, in your Uber. When you get in your Uber, you should be able to get vaccinated. And of course, zero cost at the point of care. We also know that people are really influenced by social norms and social influence. So, I think about the impact of the I voted sticker that people get after they vote. We're trying to think about how to make the I vaccinated sticker or I got the vaccine sticker as powerful an influence. And that does a lot of things. That signals that you've sort of done this important thing, that you've sort of participated in a social good, and lets other people see that it is a social norm. We can also think about things like credibility enhancing displays where we get mayors or CEOs or celebrities to vaccinate publicly on social media or on TV so that people see that this is something that's sort of being done by leaders as well. And finally, I think we need to take advantage of the fact that we're going to have some demand, some supply constraints at the front end, right? We won't be able to get everybody vaccinated all at once. And I think there's ways for some folks to sort of use that to generate demand. So can we get people to kind of pre-commit to be a vaccinator when the vaccine is available? Because we know we value things more when we can't quite have them, and we like to be kind of an early adopter. And I think the final thing I'll say around all the behavioral science strategies and all the barriers we're trying to address there is that we need to test this stuff. Nobody knows right now what nudges or behavioral interventions or communication strategies are going to work best. And we can imagine that what works best for a Black church in Philadelphia is not going to work for a small town in the Upper Peninsula of Michigan or a chapter of the Navajo Nation in the Southwest. So I think paired with the behavioral science strategies, we need kind of rapid cycle testing to really learn quickly what works and for whom, because we have a narrow window of time to get this right. I think behavioral science can be really helpful here. It's an exciting time to be a vaccine acceptance researcher and a behavioral science and behavioral scientist, and really looking forward to that challenge. So let me stop there, Mario.
Thank you. Thank you very much. That was very helpful. It's clearly a complex situation, but we do have some tools and there are some complementarities with other tools. So thanks again. Professor Salmon, I want to ask you the same question, essentially. What do you see as the root causes of vaccine hesitancy in the COVID-19 context? And I know that, among the work that you have done in this space, that you have considered the role of communication strategies. Please tell us about that and share your perspective more broadly.
Yeah, thank you for the opportunity to do so. And, Alison really laid out a lot of these issues quite well. I would just say she may be a bit more optimistic than I, but there's lots of room for optimism. I mean, keep in mind, before all of this COVID started in the end of 2019, so at least before we recognized the pandemic, WHO declared vaccine hesitancy a top 10 global health threat, and we were seeing reoccurring outbreaks of measles. In fact, we almost lost our measles elimination status that year. And a part of the issue then was a lack of trust in government and public health, and misconceptions around a pharmaceutical industrial complex. And I lay this groundwork because, not that I think that the traditionally vaccine hesitant or anti-vaccine are going to be our problem here, but I think it speaks to how pervasive these issues were in our society before COVID, where roughly 1 out of 3 people, 1 out of 3 parents were hesitant about vaccines. And then looking at how COVID was responded to in this country, and major reductions in the credibility of our public health agency. I mean, in most situations, CDC would have led this whole response, and it would have been CDC on TV every night. And that's not what we saw. And we saw the science undermined, and we saw politics driving the public health science and the response. And that really undermines trust much further. So we're in a situation in rolling out this vaccine where we were already struggling with the credibility of our public health agencies and of public health and science. And that's really been deteriorated further. So we see very substantial proportion of the population doesn't think that COVID is a serious disease. People say, the flu is worse. Many people don't get the flu vaccine. People are questioning whether this is, a meaningful pandemic, and maybe the doctors and health systems are getting paid more to diagnose COVID, and that's why there's so many deaths. And fundamentally, if people don't believe the disease is serious, why would they get a vaccine? And that's a huge challenge for us to overcome. Coupled with that, the Operation Warp Speed, which I think speaks to the priority by which we developed a vaccine, which is truly remarkable within a year. But it's been perceived as shortcuts, and that has not been the case. But people are not as comfortable with new vaccines and new drugs and new biologics. And if they believe that shortcuts were taken, that further undermines the process. And up until now, that's clearly not been the case. I mean, there were major financial risks incurred by the government, and in particular, manufacturing vaccine prior to phase 3 results, but that doesn't shortcut what we know or the safety of the vaccine. And this is the climate which we have to roll out this vaccine. And at the end of the day, a vaccine doesn't save lives, it's vaccination. And we probably need between 60 and 70% immunity levels to control this pandemic. And we know very well through infectious disease epidemiology that there needs to be homogeneous coverage. I mean, measles is a great story. Pertussis is also been shown that these clusterings of vaccine refusal, whether it's social or geographical clustering, undermines community immunity. So we need high coverage across the nation and within communities. And it's a tremendous challenge. I think that there are a few messages that could be used broadly to everyone. Talking about the seriousness of the disease, that's messaging that could be broadly delivered. Talking about the process by which the vaccine will go through FDA review and their VRBPAC advisory committee and then ACIP, well, that's messaging that could be broadly useful. But beyond that, we know, especially in the vaccine world, that we need to tailor messaging. And I really like the way that Alison started by basically audience segmenting the population. And that's exactly what we need to do. And then within those that are hesitant, it's not enough just to put them in that group. You need to understand exactly why they're hesitant. And then you need to figure out how to respond to that. And we do have tools in the vaccine communications toolbox. We know approaches like the University of Colorado calls pivot with MI, motivational interviewing. And we know approaches, but it's a lot that needs to be done. We need to know what the population thinks about the disease and the vaccine. We need to know how it varies by subpopulation. We need to know what credible sources are among those subpopulations. And then we need to know how to message within those individual areas. And then we have to be able to do that. So a mass communication campaign isn't going to solve this problem. We know that clinicians are usually the best source for most people, and we have models of training clinicians on how to talk to the patients in public. But that takes a tremendous amount of effort to scale up, to teach those clinicians how to do so. And so I think our challenges are really quite large. And as Alison said, it's an exciting time. With crisis can come opportunity. But I think we have a lot of work to do to really make this work. And if we're not able to put all these pieces together and address people's concerns, and we may very well end up with a fantastic vaccine that has a far lower impact than we really need it to have. So thank you. Let me end there.
Thank you very much. It is a challenging task, and we will need probably more than one tool again. And in this spirit, I will turn next to Robert Litan. Robert, you're an economist, and you made a proposal earlier this year. Your proposal is that we should provide financial incentives to induce people to get vaccinated. Your proposal received a lot of attention. It was also endorsed by other economists, including Professor Gregory Mankiw in a New York Times opinion piece. So, Robert, what is your proposal? How much should we pay people, and how would your proposal work?
Thank you very much. I'm privileged to be here. I've been a patient at Johns Hopkins, so I'm grateful to Johns Hopkins. I'm also an alumnus at Penn, so Alison, you're doing great work, proud of you. And so I'll tell you how I came to this proposal. It was really from a very personal angle. I'm 70 years old, my wife is 70, so we're high-risk people. And in the middle of the summer, I'm worried about all the things that Dr. Fauci is worried about and why all of us are worried. And that is that there won't be a high enough take-up rate. And this, of course, was in the middle of a political environment that made the whole thing very politicized. And so my wife and I were talking, how are we going to get to a point of true herd immunity? Not the fake herd immunity that Scott Atlas has been talking about, but literally to the point where we don't need to wear masks and don't need to social distance at some period of time, or technically, as the scientists say, where the rho, which is the rate of reinfection, the rho falls below 1 and the virus basically dies away. So here's how the proposal came about. I was very familiar with the work of Dr. Michael Osterholm, who's now on the Biden Advisory Task Force, because I had done some consulting work about 15 years ago in pandemics. Followed his work, and he said that we need roughly a 60 to 70% herd immunity target for the population as a whole. And at the time, Dr. Fauci was saying it would be really great if we could get a vaccine that was 75% effective. So if you do some elementary math and divide 0.75 into 0.60, you get a number of 80% being the required vaccination rate for the country at that time. And the public opinion polls, as Dr. Fauci pointed out, showed that only 50% were willing to take it. There was a Gallup poll actually in August, which said 65%, but the numbers were well short of the herd immunity target of 80. And so we thought among ourselves, and I particularly as an economist, I thought, well, you can mandate people to take the vaccine, and we'll get to that in a minute. But I felt that in such a highly politically divisive environment, forcing people to take the vaccine in a world in which people are really already angry about wearing masks, and even some people threatening to kill the governor of Michigan for talking about wearing masks or mandating masks, we thought it was really a non-starter to mandate masks. And I will get to that, as I said, shortly. So the only other incentive that I could have thought of would be to pay people to actually take it. And there's no good evidence on how much it will take to switch the people who are otherwise reluctant. So I made a seat of the pants judgment. I asked myself, well, would I do it for $100 or $200? And I said, nah, I don't think so. But I said, what if it were 1,000 and I have a family of 4? That means $4,000. Now I may be really hesitant, but for $4,000 to take the vaccine, especially if Dr. Fauci says it's okay, that may be enough to flip me. And so I proposed $1,000, but with a twist. I said that in my original proposal, let's pay people $200 at the time they get the vaccine, and then hold out the other $800 and only give it to them when the national target of, let's say, 80% is reached. So it gives people very strong incentives to tell their friends, their church members, their coworkers, their people on their social media to basically say, look, go out and get the vaccine, because then we can all collect the money. And then they get the balance. So they get the full $1,000. So that was the original idea. Now, since then, Pfizer's come out and Moderna's come out, and the vaccine may be 95% effective. And if you do the math, it works out that now all you need is roughly a 65 to 70% vaccination rate, putting aside the cluster problem that Daniel just talked about. So the current public opinion polls show that the percentage willing to take the vaccine, according to this week, had actually risen to 58%. Now, we don't know whether that's actually going to happen once the vaccine rolls out, but 58 is not far from 65. So we may get there without having to pay the vaccine. Now, let me interject. When I proposed this idea, it was only as a plan B. It was only pay the people to take the vaccine if everything else doesn't work, like the doctor consultations that we're talking about, like the public service announcements, like the people from the government, they're going to persuade people, et cetera, to take the vaccine. If we can't get to 65 then, and let's say we're only at 50 or 55, I think then we ought to have as a plan B in the closet, paying people to actually get it. And to be clear, everyone who takes the vaccine will be paid. So it's not just the people who are waiting at the very end and deciding, well, pay me in order to get it. You have to pay everyone, which means that in a sense, you're wasting some money on people who had already taken it. But I argue in my piece that it's worth it from a national society point of view to spend roughly $250 billion to vaccinate the public. Because in order to do that, I mean, the benefits from that are that you basically get an economy that goes back to normal. You get Main Street, you get sports events, you get life being back to normal. And I would think that most Americans, especially Main Street entrepreneurs and people that want to go back to sports events and want to go back to concerts and et cetera, and want to go back to normal life, I think they would say that's a bargain, especially considering the costs that we've had to pay and will continue to pay and should pay for people that have been harmed economically. And I'll just address one final issue, and that concerns the ethics of this, because a number of people have responded to me, is it unethical to pay people to take the vaccine? Well, I would point out that we do have economic incentives now for people to quit smoking. If you look to insurance companies, whether it's car insurance or auto or life insurance, they will give you a discount if you don't smoke. And so in effect, this is basically the same thing. We're going to pay you in order to achieve a larger social good to achieve herd immunity. And the final point that I would raise, compared to what? If you want to compare this to a mandate, and by the way, a mandate, you can't actually force people to actually get the jab in their arm. What you could do is you could say, unless you get the vaccine and have a card, you can't get into public spaces like restaurants or like sports events or whatever. But I think that even though these mandates, which would have to be established at the state and local level, because I don't think the federal government has the authority to do it, but at the state and local level, are you going to have every state mandate the vaccine in a world in which a lot of the states aren't even mandating masks? It seems to be implausible. So I don't think mandates are the answer. I think, as I said, they're politically divisive. And we all know from the proverb that it's much easier to get people to change their mind through honey rather than vinegar. The honey is the financial incentive. So that's why I would urge this as a plan B to have in the closet. Thank you.
Thank you very much, Robert. As an economist, I appreciate the merits of your proposal, and it's right. We do subsidize activities or actions that have positive externalities or that generate the benefits for society when otherwise they would be underprovided. And I'm sure there will be reactions. I can already see questions.
Yes, there will be.
Yeah. But before we open this up and the other considerations that were offered earlier, before we open the debate, we want to hear from our fourth panelist, Dan Polsky. So Dan, you and also Alison, you were both members of a committee that was established by the National Academies of Sciences, Engineering and Medicine that produced a framework for the allocation of vaccine for the coronavirus. One of the sections of the report was devoted to addressing costs and financial barriers. It's a broad topic. I would love to hear from you about what those considerations are.
Well, thank you. It's nice to go last. This, I think, connects, some of my thoughts connect to a lot of what's been said. You know, Alison really emphasized, we want this to be zero friction, zero cost, zero hassle. And the other Dan, the first Dan said vaccines doesn't save lives, it's vaccinations. And I really appreciate what Robert had to say, because this idea that when you go to get vaccinated, you're not just helping yourself, you're helping those around you. And so, you know, the economist says, well, we want to internalize the externality. So I guess I'm going to speak a little bit to that, in that we really want zero cost. And I think the message is already getting out there to the public that the vaccines are going to be offered at zero cost. But, you know, some of the work I do is a little bit in the nitty gritty of the healthcare system. And when you kind of pull the veil over how they're going to achieve this, there's just going to be a lot of holes in because we have a pretty fragmented healthcare system, and it's not like the same system for everybody. And so there are going to be holes. And I think that's something we need to pay a lot of attention to, because this message that vaccinations are going to be free, even if it happens to one of your neighbors, that message is going to, you know, make it difficult for people to trust the system and show up. So we want to minimize the challenges that exist because of cost, particularly as we just really try to move very quickly to achieve a high vaccination rate. So I looked on the CDC website. It says vaccine doses purchased with US taxpayer dollars will be given to the American people at no cost. However, vaccination providers will be able to charge an administration fee for giving the shot to somebody. Vaccine providers can get this fee reimbursed by patient's public or private insurance company, or for uninsured patients by the Health Resource and Service Administration's Provider Relief Fund. So the public may expect no out-of-pocket costs. However, I just want to make 4 potential exceptions. Not all doses distributed will have been purchased by US taxpayer dollars. While insurance will cover administrative fees for approved vaccines, an out-of-pocket provider can still bill the patient if reimbursement is not sufficient from insurance. 3, sufficient reimbursement for administration is essential. Particularly if hard to reach populations are to have equal access to vaccines. So from number 2 to number 3, there's a tension. We actually want to hold payers accountable to give adequate reimbursement rates. And the way we do it is through this kind of exception for out-of-network balance billing. So that could happen, which would be terrible. But on the other hand, if we don't have some pressure on payers to offer adequate reimbursement, we won't get the providers showing up, particularly in the hardest to reach places, which can be the most expensive. And finally, there are likely over 30 million uninsured. The provider relief fund is not sufficient to guarantee access to these hard to reach populations. So there are not sufficient funds to reach these populations through community pub programs. States have requested $8 billion. And I'll add that President-elect Biden has promised to seek $25 billion to, as he says, guarantee the vaccine gets to every American, no cost once he's in office. So more funds are needed. So my point is that we've spent $10 billion of taxpayer dollars on Operation Warp Speed to develop the vaccines. Money well spent for sure, but a vaccine, as Dan said, does not work unless people get vaccinated. Not everyone will have zero out-of-pocket costs unless states have more resources for that last mile to reach the hardest to reach people. And that job of the last mile requires state and local health departments, and frankly, they're broke. So I'm going to stop there, and I'm looking forward to engaging with the other panelists and the questions in the chat. Thank you.
Thank you, Dan. Great, thanks so much for this first round of comments. I will now open this up for discussion. Are there any reactions from the panelists to what the other panelists have said? Who wants to go? I'm sure there are. Who wants to go first?
I'd be happy to jump in on the incentives question. This is something we spend a lot of time talking about and researching at the Center for Health Incentives and Behavioral Economics at Penn. Really intriguing question, and I applaud the kind of simplicity and clarity around a plan like $200 for every person who gets vaccinated and an $800 bonus when we're done. The devil is definitely in the details with financial incentives for health behavior change, and just some things to consider if this is an idea that we continue to carry forward. So one is, while I love the idea of sort of holding back some of the payment until everybody gets to a herd immunity threshold, the reference group for that everybody else is really important. And I'd probably suggest that comes down to the county or zip code or health system or school district level and not the whole US, because that won't be a meaningful reference for folks. Secondly, I can think of what I would guess would be more effective levels at which to incentivize vaccination. So we already, for example, do quality payments, quality bonuses for providers that get child vaccination or flu vaccination to a certain level. And I would argue that with limited resources, incentive dollars might do better at the provider level so that they can use their ingenuity and their knowledge of their patient base to reach the threshold that's needed. Because it's definitely the case that not everybody needs a $200 or $1,000 incentive to get vaccinated, and so there may be better ways to use those funds. And finally, this came up in the chat too. I saw, we do have to think about what incentives signal to people. And one thing they can signal is that this must be a hard or difficult or dangerous or unpleasant task if they're giving me an incentive to do it. And I don't know that that's necessarily the message we want to give people versus this is actually quite a very easy and safe and sort of normal thing to do. So I have about like eight other thoughts, Robert, that I'd love to talk offline about, but just some things about in the sort of devil's in the details aspects of financial incentives.
Mara, you want me to answer real quickly? So the county reference point is a great point. It's an issue of complication, but you're absolutely right. It also addresses the cluster issue, which one of the Daniels pointed out is an issue. So I think that's point well taken. The problem of paying people who are otherwise going to get the vaccine, I think, is just something you got to live with. I used to be a research assistant for a famous economist named Arthur Okun, who had this great analogy called a leaky bucket, that every government program has a leak in it. And do you not spend the dollar simply because 30 or 40 or 50% is going to leak out of the bucket if you're going to help the other 50%? And in this case, we have a leaky bucket. You're going to pay people that are otherwise going to get it. I'm willing to take that because frankly, there's really, and I, pardon using the pun, there's a booster shot element from an economic point of view to giving people money. I mean, we just gave people, back in the summer, $1,200 a person as a fiscal stimulus. Here's a case where we're going to pay people, but actually get a social good out of it. And the economy does need a fiscal stimulus, which is not forthcoming right now. So actually, don't worry about paying people who are already otherwise going to take it. So that to me is not a problem. The final point is a signaling point, which a lot of people have raised, and you're absolutely right. Which is why I think you need a higher rather than a lower payment. I mean, I think a $200 payment's not enough, but $1,000, I think, you have to weigh these things, there are some people that will interpret that as, hey, if it's really $1,000, there must be something wrong with it, versus $1,000, I'll take the $1,000. So I think, and that goes to the issue of we don't know what the right price is, and when I initially started this, I started thinking, well, the government could gradually start raising the price. And by the way, you could still do this in this proposal. You just have to be sure that whatever increase in price that you do, and I'm not saying you need to increase the price, but whatever you do, you have to make clear that everybody who's already getting the shot gets the benefit of the increased price. Otherwise, people will wait to take the vaccine. So you don't want that. So it's a good point. But again, as I said, compared to what? And as I said, I don't think mandates are a preferable solution. I mean, other people will have different views. But I think that compared to mandates, I'd still rather people have an economic incentive. And economic incentives, we know as economists, work in too many other contexts. Why shouldn't they work here?
Now, I wonder if I might ask Robert a question. If you think about the impact of economic incentives and start to audience segment as Alison did, who are you going to impact? Because it seems to me that people that, pretty much wanted to get the vaccine anyway, but they get it faster because it's financially incentivized, just like easy access will get people over that hump. Well, that makes a lot of sense. And maybe people that are a little bit hesitant, but they're pretty close. As you said, well, Dr. Fauci said to do it anyway, and I could really use that $4,000 for my family. But people that are not at all sure that it's in the best interest of themselves, and in particular their children, it's hard to imagine you're going to financially incentivize somebody to say, well, I'm not really sure this is in the best interest of my child, but I could really use $4,000. So I wonder what your thoughts are on that. I mean, who is it? I have no doubt that if you were to financially incentivize, especially at the scale of, say, $1,000, which of course is relative to what your income and assets are, that it would make a difference. I'm wondering among whom, and is it enough of a difference?
It's a very good question. So I'm assuming there's a baseline of somewhere 40 to 50% are going to take the vaccine regardless. So really, in order to get that herd immunity level, we need another 20% of the population. And, of the people that aren't going to take the vaccine, which is 50%, some portion are anti-vaxxers and they just won't take the money. I mean, they'll refuse. And we have no good estimate of how large the population is of anti-vaxxers, but let's say it's 10 to 20%. So now we're down to about 30% of the population who are potentially flippable. They're the people that I'm going to target. And I'm not going to speculate as to socioeconomic status or whatever, but I suspect they'll be at or below the average median income or the median income. They may be more predominantly minority than others, because Dr. Fauci showed this statistic, which I've seen in other studies, that Blacks in particular are reluctant to take the vaccine in part because of the historical record that they were experimented on in the 1920s, in the early 20th century. And a lot of Black people remember that. And so they are suspicious, rightfully so. All I can say is, I don't think all the PSAs in the world and having LeBron James on TV is going to change that. It may change it a little bit. I really want to think about giving a financial incentive. So, in part it's minorities, and in part it's just other people who are just, reluctant to get out of the house, or it's too much inertia. But for $1,000, they'll get out of the house. And that's my view. And those are the people we're going to flip. But that's roughly 30% of the population. If we can get them to take the shot, we're home free.
Can I ask a question for the panel? So I guess either way, whether it's for what everyone on the panel has discussed, it seems to me, and correct me if I'm wrong, but I think more federal resources are needed. Like if we did not put more money into upping vaccination rates or addressing communication, incentives, and provider payment, that last mile, public health, however you want to do it, I think more federal dollars are needed. And maybe I'd like this to come up in our next panel around the modelers, but I think one justification for this would be, if the economy, if we hit, some rate where we can go, I mean, it's not just going to basketball games, and believe me, I want to start going. Sixers made a great trade this week, but there's also just the economic activity, and there's so much welfare that can be created once things start to loosen up a little bit. If that happens faster, the economy starts chugging along faster. It's not just kind of non-measurable welfare, but like returns to the taxpayer coffers. If we can make that argument, that 25 billion is nothing. And I guess I wonder what the thoughts are on that, and whether, our collective mind should be like, we need more resources. There's a lot of ways we can get to that herd immunity rate or higher rate. But if we spend our time thinking about which way to do it, we might come up with $0. So anyway, that's a thought, and I'm interested in what other people have to say, and whether there's kind of unanimity in that if we didn't get more resources from the federal government, we're going to come up short.
I'd love to respond to that. And I would agree with you wholeheartedly, but go a lot further. So I think that the whole premise of this program has been, if we build it, they'll come. And it's almost back to the polio vaccine days. So we spent $10 billion developing vaccines, which, I mean, I don't want to base my opinion on press releases, but at least it's suggestive that they may be very effective, and presumably there wouldn't be press releases if it also wasn't very safe. $10 billion to develop a vaccine, and which frankly, if you look at the economic losses of COVID, that's actually not even that much money. But where's the focus on once we have a vaccine? To think that if we build it, everyone is going to come and it's just going to work out great is absent the reality of certainly this century. And I agree that there's infrastructure needs in the local and state health departments. I mean, unbelievably so. I recall this summer talking with people at the local level where their immunization program were being furloughed because of lack of funding. I mean, how can that be? We're getting ready to launch a vaccine and we're furloughing our local public health immunization people, but the needs are far beyond that. What if we spent 1% of that budget on understanding what people think through more rigorous than whatever poll somebody happens to publish? And there was a question about, well, are these estimates better than the election polling? And I mean, it probably depends on the estimate and what polling was done. But where's the focus on understanding what people think and developing and implementing strategies to address the concerns of the public? And so I think the needs are so much. Simply having a vaccine is not enough. And why has the focus been entirely on, we'll get the vaccines quickly? And the conversations we're having now are starting 8 or 10 months too late.
Yeah.
And at this point, all of this we should be implementing this, not talking about what needs to be done. And I think it's really reminiscent of the challenges we faced historically in vaccines, where there's been inadequate attention to what the public thinks and their values, and rolling out vaccine programs in a way that meets the needs of local communities and subpopulations. And so I couldn't agree with you more, Dan, that there needs to be funding for local infrastructure. And I think a lot more work in this area as well.
To build on that, I see a couple of really important tensions here. One is, traditionally we've looked to the CDC for leadership on this, and like we need the CDC to sort of get back on its footing to be that national leader. We also deliver vaccines through we have these 64 existing jurisdictions. Most of them are states, some are cities, some are islands. And like that's who's going to take vaccine allocation. Those are the entities that are going to receive allocation through the program. And that's where we need sort of the expertise, the rapid trialing, figuring out whether incentives is right for our community. And the tension between needing federal dollars, but those dollars need to really fast, really quickly get to the jurisdictions, and partnering with communities and community-based organizations that have local expertise. And I agree with Dan 100%. That needs to have started, back in the summer. I feel like we are already going to be behind on day one when we have our emergency use authorization.
So much of this discussion highlights that different strategies might be needed to induce different types of, or address different reasons for this hesitancy or resistance. And then you refer to a question that, for those who are not looking at the chat, there was a question in the chat: is it possible that the polls about intent to get vaccinated are as accurate as the pre-election polls? Well, there is, people's opinions change. And as Robert mentioned earlier, we already see that a slightly higher fraction of Americans, according to the latest polls, are now willing to, saying that they would be willing to get vaccinated, plausibly maybe in response to the news about the efficacy of these two vaccines, Pfizer and Moderna's. But I wonder do we know, how much do we know about how people change their mind, how people form expectations and intentions, and how they change their mind as new information becomes available? I'll give you an example. I was, when the early Pfizer news of 90% effectiveness came out, I talked to my mom. I talk to my mom every day. So that day, and I told her, have you seen the news? And she said, yes, only 90% effective. Like, she was disappointed. For some reason, she was expecting a higher effectiveness. And I explained to her, and my mom is, she has a college degree, but she's not a scientist, but she's educated. And so I wonder, what do we know, again, about how people form expectations and how they react to new information? Do we know enough? Who wants to go?
I'm happy to respond to that. I'm sure Alison, maybe others can as well. But the short is it's really much easier to impact people's views and attitudes as they're being formed than it is to change them. And once somebody has made up their mind on something, it's not that it can't be changed. Sometimes it can. It's just really hard. And you have all sort of cognitive biases that impact it. So people, once they've made up their mind, they find information that support their views and their beliefs. And what doesn't support their views, they either tone out or they find a way to make it fit their views. It's really hard. It's possible. We did a study among pregnant women trying to impact maternal and infant vaccine uptake, and we in particularly focused on first-time pregnancies because of this reason. We thought that, in fact, it would be that's when people were forming their views, when a woman becomes pregnant for the first time. We found that about 75% of them had already made up their mind by their first pregnancy. And and we did have an impact on what they thought, and we had an impact on behavior, but it's much, much, much harder. And I think this is part of why I'm less optimistic than Alison, because you have people, substantial proportions of the population, that believe our election was a sham. We have people that believe that COVID was a hoax to sink the election for the president. I have friends and family members that say things like, well, the flu is worse than COVID. These are people who've made up their mind already. And can we change it? Perhaps we can, but it's much, much, much harder. And that's a lot of why I say we're months behind where we need to be.
So can I jump in on this? So just to follow this, because I think everybody should address this. Let's suppose, Dan, you're right, that for all the reasons that you said, that people are as hardwired about the vaccine as they were about the election. They're not going to change their mind. Let's suppose the thing is rolled out, and with all the hoopla, we're at 50%, okay? And we all know that we need to be roughly at 70% take-up rate in order to get to a point where we can go back to normal, without the masks and without the social distancing. So what do we do if we have that 20% gap? Now, one answer people have told me is, well, we'll just live with it and we'll just wait for therapeutic advances to make the virus less deadly. So we'll just live with it, and eventually, there'll be fewer people that will die. It won't be so bad. People won't get scared, and it's just part of the background noise. And a lot of serious people have told me that, and we may end up there. I personally don't want to end up there. I would want to get to the 70%, and as I said, at that point, we only have two choices: mandates or pay people. I mean, to me, that's it. And unless anybody else has any other brilliant ideas, and this is assuming we've already done the PSAs and everything else to try to nudge people, what do we do? And to me, by the way, paying the money in installment, the $200 and then the $800 holdback, means that we don't really have to spend that much in the first round. $200 worked out, among all people, is roughly $50 billion, which is not a big bet. And if it doesn't work, that we get to the 70%, we don't have to pay the other $800 and the other $200 billion. But if, in fact, that initial $200 gets us up to 70, I'd be glad to pay the other 800 because we got to our goal. So to me, spending 50, just, again, as a plan B, to at least see if we can nudge the number is worth trying, because I don't see us. I think a mandate could actually be counterproductive and in this environment. That's what worries. That's what worries me.
Yeah, we don't mandate vaccines covered by EUAs anyway, so that's off the table right at the beginning. I just want to come back to sort of how our intentions forms and motivations form, and bring in a couple of comments from Dr. Cindy Avery in the comments, who's a doctor in Down East Maine. She's noting in her practice more interest this year in flu vaccine than in prior years. I think people are hearing that message, that it is so important this year for a number of reasons, including the fact that we want to keep people out of the hospital for flu so that we have COVID beds. But it really raises the importance of sort of anchors and reference points, right? So a lot of people don't get the flu vaccine every year because one of the things they know about it is that it's only 50% effective, which is true in most years. We have better years and worse years, but it does prevent severity of illness, et cetera, and you're contributing to herd immunity. If we have vaccines now that are 90% effective, one opportunity, Mario, with folks like your mom, would be to say, compared to, this is so much better than flu vaccine. Don't anchor on 100% because we don't have vaccines that are 100% effective. Look how much better this is at preventing COVID than the flu vaccine is at preventing flu. And I think also the opportunity that Dr. Avery mentioned to sort of anchor people's COVID vaccine decision on their flu vaccine, like you vaccinated for flu this year, you should do COVID as well when it's available, is also an opportunity. And just a shout out to all the PCPs who are going to be doing this vaccine counseling over the next year. Thank you in advance.
We all need talking points from Alison for our mothers.
Okay.
Yeah, so my concern here is that the anchoring might have already happened for some. Yeah. And if they've anchored at 100%, then we have a problem. If they anchored at 50%, then great, because the surprise will be positive and plausibly, beneficial. But otherwise, so again, we're coming back to the importance of communication.
Yeah.
Dan?
I'll make a few comments. One is I can't help but respond to Dr. Avery, having spent a lot of time in Machias. I know Down East Maine well. And, one of the points she brings up is the importance of primary care providers and the need for help for them, because often our clinicians are not trained in communication. And this is a really complicated area of communications. There was another comment about, how did this happen so quickly? Did we just get lucky? And, does this mean shortcuts were taken? And this is such an important question. The reason it happened so quickly is a few reasons. One is we took advantage of new technologies in vaccine development. Number two, a tremendous amount of money was put forward. So multiple candidates in very large trials where, much of the clinical trial capacity of the nation was focused on COVID vaccines. And that's not normally how this works, right? And then the paying for production prior to phase 3 results. The only example of that I'm aware of was polio vaccine. So that has a huge reduction in time between when a vaccine is, found to be safe and effective for use. and when you have vaccine available. So up until now, there have not been shortcuts. The phase 3 trials are really quite large, but we also have to understand that emergency use authorization is not how we typically license a vaccine. In fact, it's not a licensure. The only example for that for a vaccine was anthrax that was for a specific population. And it's not going through a biological license application. So this perception of, cutting things short, we have to be really careful with an EUA. And studies already done show lower uptake with an EUA. And importantly, the FDA is going through the VRBPAC, a public advisory committee of independent experts. So we're not following the normal procedures there. And consequently, we need to be thoughtful. We need to be careful. We need to explain to people what the VRBPAC is and let them see what it looks like. And be very careful as we move forward. I'd like to just say one more thing about mandates. I don't think that's mandates, and I've spent decades studying mandates, is something we should even be talking about now with any serious consideration whatsoever. I mean, firstly, with an EUA, it would never happen. But even if it went through a BLA process, no state's going to put in a vaccine mandate when half the population doesn't want the vaccine. The Association of Immunization Managers has put out, these are the people that run the immunization programs that Alison referred to, put out criteria for when to consider mandates. And this meets almost none of them. And I don't think it's reasonable to think that any state is going to pass a mandate for the general population. It wouldn't be implementable or enforceable. It would be incredibly counterproductive. So, when I get calls and questions about it, I think the point is that's not going to happen anytime soon. And we just need to be careful when framing conversations that we don't give the impression that that's something that might be on the table, because I just don't think that it is.
So one specific concern that comes up in surveys and in the discussion is that the possibility that some people might want to free ride. So this is the first generation of vaccines. It looks like they are effective, but perhaps the second generation might be better. So some people might wish to wait. So how do we address this type of rational hesitancy?
Yeah, and I think some of the recent survey work that's been done has been really helpful in adding, yes, I'll get it right away. Yes, I'll get it, but I'm going to wait. No, I don't plan to get it, or I don't think I'll get it. And that's a big chunk of people. Sorry for my loud doorbell. I've heard people say, this was a few months ago, but I've heard friends say, I'm waiting for the European one. I don't even know what that means. Lots of people saying, I'll get it when Fauci gets it. But I think that's where some of these sort of social norms and credibility enhancing displays can really make a difference. So if people see that other people aren't waiting, other people are going for it, that can be an important signal that you don't have to wait. But I can understand people wanting to wait and see how the safety profile looks, the side effects profile looks in more than 30,000 people. That post-market information that we get is really important, and I don't blame people for wanting to sit on their hands for a bit.
I'm going to jump into the waiting thing. I think the fact that doctors and healthcare workers are getting it first is really important, because we'll see from that cohort whether those people get sick. By the way, if there are significant side effects from that community, the whole vaccination program, at least in the first round, is going to be dead. All right. I mean, so the doctors have got to pass the test, flying colors. And then once people seeing their own doctors and their nurses not having, major side effects, I think that may bump the rate up a bit, especially as doctors talk to their own patients. But the waiting phenomenon also is rational in the sense you want to see about the side effects, because the FDA approvals are only based on a 2-month waiting period, and we don't know about the long-term side effects. So that's why, for example, when I talk about my proposal about to pay people, I wouldn't even think about paying people until I knew there was at least a 6-month period where we at least saw what happened in terms of waiting effect and effectiveness. And also the other effectiveness thing that people haven't mentioned, we don't know how long the vaccine is going to be effective in this round one. It could be 6 months, it could be a year. There's been a lot of speculation about this. And so I wouldn't rush to pay people until we have more data on how long the effectiveness really lasts. Because in my calculations, for example, in doing the doing the herd immunity rate, I did not factor into the take-up rate, people who have already had the virus. Dr. Fauci addressed this morning. You cannot assume just because you've had the virus that you don't need to have the shot. And there's going to be a lot of false belief by people who have already had the virus say, hey, I don't need the shot. When in fact, I think most doctors are going to say, yes, you do, because you may not be immune. You may be immune for 2 or 3 months if you've had the disease, but you can still get it again. And that's another thing that could depress the take-up rate, is all the people who have had it, by the time the thing comes out, they'll say, that they don't really need it. So we've got a ways to go before I think we even get to the payment idea, all for the waiting reasons that that Mario and Alison have raised. It's something that we could expect.
Can I pick up on that waiting question?
We are planning to stop at 10:05. Some of our panelists have to leave, and we also want to give our audience a little break before the next panel. But please, Dan. Polsky.
Oh, just very quickly, so the prioritization scheme, the folks that are early on, ironically, are the folks that are also have put themselves on the line in so many ways during this pandemic, with the healthcare workers, first responders, and also the most vulnerable, the elderly, those with chronic conditions. It makes sense to give it to them first. They're the most vulnerable, but they're also most likely to take, least likely to want to wait. But on the other hand, there could be some, we're going to wait to see how things go, with, my 90-year-old mother. I mean, she's 90 years old, she could die for a number of reasons, frankly, and it might have nothing to do with the vaccine. So we have to be careful about messaging as well. Everyone's going to wait, but if the most vulnerable are getting it first and bad things happen to vulnerable anyway, it's going to be a tricky period. It's also ironic, if there is a challenging safety profile, that those that have put themselves on the line during this pandemic, in some ways we're asking them to do it again. Something we need to be conscious of.
I'm hoping not as bad as Shingrix. That's kind of my anchor for this.
So perhaps this will be the last question. And it's a very important one, again, in the spirit of addressing specific barriers with specific solutions. And this came up quite a bit in the chat, and also came up earlier. How do we address the community mistrust due to the historical racism in science, and particularly in the US, in regards with the African Americans and their history. And so how do we address this specific concern, this specific source of mistrust that leads to, in this case, among other things, vaccine hesitancy?
If I'm the Biden administration, I mean, the first thing I go to are my influencers. I get other famous Black entertainers, Black church leaders, etc., to spread the message, and hope that works. I think that's going to be required, because this mistrust, by the way, is rational, because people were experimented on and they know it.
I mean, it's such a great question, right? Because we're prioritizing people of color for reasons of beneficence. We're saying they're at higher risk of contracting the disease and morbidity and mortality, and therefore they should get a vaccine first. It's classic public health, prioritizing at-risk populations. It makes perfect sense. But from the perspective of those communities that have been historically experimented on and mistreated, and whether we're talking African American or Native American, that prioritization may be perceived as they're experimenting on us again. And I agree, you got to go into the local communities and work with them. And I think you need to speak with their local leaders and have a process by which they're engaged and a part of the decision making. And to think that, we're just going to offer it to them and they're going to embrace it, given the context, I think is naive.
Agreed. I think we have to lead with a lot of humility here, but particularly from behavioral science. Like, this is not a nudgeable problem, and the local expertise is key. I'm going to do a weird disappearing act because I have a doctoral dissertation defense to chair. But thank you so much for
thank you, Alison,
very
much. And we're going to end the formal panel here. Thank you so much to our panelists, and thanks to the audience. This was an incredibly informative discussion, at least for me, and hopefully for the audience as well. Some of us might choose to stick around. Otherwise, the next panel will start then. Is it 10:15?
Yeah, the next panel will start at 10:15, so folks can
10:15.
take a little bit of a break. I'm going to put this slide up to hold the room, if you will. Please come back for this terrific panel. But I guess informally we can answer questions or something. I'm not sure. We could engage the chat. What do you think, Mario?
We could engage the chat, or we could, but the chat, I guess most of those questions might have been addressed to the
Yeah, I guess feel free to continue to put questions in the chat.
Yes. Or give the audience a little coffee break, or the opportunity to stretch a little before the next panel. We don't want them to leave for sure.
Please stick around.
But
yes.
Stick around, please.
Good morning, or good afternoon, or good evening, depending on where you're from. We're glad to have you joining us for the second panel and are completing the break from the earlier sessions today with Dr. Fauci and the panel before us. This is a panel called The Pandemic in 2021, the future. We're looking to the future and setting policy priorities and filling evidence gaps. I'm Kathy McDonald. I'm a relatively new professor at Johns Hopkins. I actually arrived concurrent with the beginning of this pandemic. So I have gotten to know my new institution through those eyes. And as an interdisciplinary scientist at the intersection of nursing, medicine, business, engineering, and public health, I've been very comforted to see in my new home and in the world at large, these different fields of thinking working closely together to understand and make a difference with the challenges of COVID. This symposium today is bringing together this type of multifold view with a focus on decision makers, from individual citizens to clinical professionals to public health leaders and policymakers. We're bringing together these different perspectives, as well as those from thinking about local action at the city and county level, as well as national policymaking in both the US and Europe. We're going to pose two main overarching questions in this panel that acknowledge the dilemmas and the trade-offs for key decisions during this unprecedented pandemic. First, we want to know, what are the decision-making needs of those at the front lines of the ever-changing landscape of increasing evidence and increasing technical capacity, which includes, of course, the anticipated introduction of safe and efficacious vaccines. We're also interested in how the expertise of those in the decision modeling community can be harnessed and utilized to help all decision makers, including citizens and those serving them. So today we're responding to Dr. Fauci's reference, which I was very happy to hear, to modelers, which means decision modelers. We have a panel of mathematical rock stars in decision sciences and biostatics. They're on the front lines of the pandemic as well. They're working around the clock and across the globe to bring insights as evidence accretes. Several of our panelists, Shan Lui, Beata Jan, and Uwe Seibert, are award winners of the COVID-19 Decision Modeling Initiative, which was supported by the Moore Foundation and is a partnership between the Society for Medical Decision Making, Johns Hopkins, Duke University, and the University of Michigan. We also have a world-class biostatistician, Litan Chatterjee from Johns Hopkins. And importantly, to keep us grounded in the central challenge of trade-offs, we have Dan Gorenstein, the executive producer and co-host of the Trade-Off Podcast, which is a nonprofit health policy podcast that's been created to be a trustworthy source of journalism using storytelling, research, and conversation. Interestingly, one of the recent podcasts was episode number 80 from season 1, and it focused on vaccines and was called Good Intentions. To follow on the last panel, I know there were a lot of interest in the various challenges of making sure that vaccines get to those who need it most. And the Good Intentions podcast focused on how drug makers and public health officials are placing emphasis on diversity in vaccine clinical trials as they never have done as much before. So that's our group of panelists. And the way that this session is going to work is we're going to hear from Shan Lui about public health interventions and vaccine strategies. Then Beata Jan about vaccine distribution options in the Austrian context. And then Litan Chatterjee will talk about individual and community risk assessments to inform vaccine and other public health strategies. After those three presentations, Uwe Seibert will react to what he's heard and reflect on how his work bringing decision modeling expertise to decision makers informs understanding what's been heard. After that, Dan Gorenstein will make sure that we are looking at those fundamental questions of trade-offs and react with his perspective and questions from the vantage of pros and cons of the different approaches shared. Importantly, we welcome your questions and observations throughout. There's a question and answers spot to put your questions in. We'll draw from these as we go, and we're reserving time for this session to address as many of those questions as we can. So we will start with Sean Lee, who on each of these presentations will have to take a moment to load up the slides. And then Sean, once you've had a chance to do that, you can go ahead and share what you're learning from your work.
Okay, I'm ready.
Thank you. You can.
Thank you, Kathy. It's my pleasure to be here. I will briefly present our research on optimizing societal reopening plans and vaccine distribution strategies under COVID-19 using simulation optimization tools. The objective of research is to estimate the impact of non-pharmaceutical interventions and vaccination distribution strategies on COVID-19 transmission to control outbreaks in an urban setting. There are two primary aims. In the first aim, we have developed a calibrated agent-based simulation model for a large city use case. For example, the greater Seattle area, also known as King County, to project COVID-19 outbreaks under NPIs without widely available vaccines through the spring of 2021. In the second aim, once safe and effective vaccines become available, we plan to optimize vaccine rollout programs in combinations with NPIs for a large city to remain open and target COVID-19 elimination in the next 3 years. Key features of the model include full flexibility to generate multiple projections tailored to local information, as well as addressing the dynamic nature of the vaccine rollout. Now let's look at the modeling framework. We modified the open source FRED model to create an agent-based simulation of COVID-19 transmission. There are 4 components. First, model inputs include population demographics and contact networks that were generated from US Census data and epidemic and disease-specific parameters. We calibrated regional COVID-19 transmissibility, contact patterns, and home quarantine compliance to target basic reproduction number and outbreak trend. Second, the natural history of COVID-19 follows a modified susceptible exposed infectious recover structure, also known as an SEIR model. For each day, individuals could interact with other individuals in their household, neighborhood, workplace, and school, and may become infected. Depending on their age, individuals may become symptomatic with different severities. We also include interventions such as social distancing, face mask use, school closure, home quarantine, testing, contact tracing, and vaccines when available. We consider degrees of openness in various locations, compliance to interventions, and service capacity. Lastly, main model outcomes include population health outcomes and health service resource use. After calibrating the model following the King County timeline until May 31st this year, shown in the top figure, we found 2 clusters of parameters that meet the local trend. We further simulated different combinations of NPIs and their various compliance level shown in this table until end of May next year to explore the trade-offs. Results from aim 1 show that second wave is driven by relaxed social distancing and school reopening. In the figure below, we show 2 plausible alternative projections of daily cases between June 2020 and June 2021. Next, we simulated 300 scenarios of NPI combinations. So these yellow highlighted cells indicate NPI combinations that keep total infection below the desired level in King County. For example, here, under no face mask use, we would need lockdowns and school closure to control outbreaks. Displaying results from all NPI combinations, one key observation is that high compliance for face mask use is the most important driver keeping total infections low. Society and school may remain open if 75% to 100% of the population use face masks. Moving on to aim 2, when vaccines become available next year, allocations need to balance multiple goals with equity considerations, such as containing outbreaks, reopening society, and protecting vulnerable groups. We will model alternative allocation strategies, some examples are shown in this list, while considering spatial and social equity to understand the trade-offs between competing objectives. We will also model and compare outcomes from established allocation guidelines. Lastly, there's one more thing I would like to highlight. As we can see from data, social vulnerability correlates with total infection in the community. For example, the dark blue neighborhoods have high infections and high COVID-19 community vulnerability index. We're using detailed spatial information in our modeling approach, and we hope findings from this work will provide actionable insights to policymakers. Thank you very much.
Thank you, Sean. That was really helpful to see. We're going to now get to hear from Beata Jan. And Beata, if you could share your slides and go ahead and let us know what you've been learning with your work.
Thank you. Yeah, my name is Beata Jan. I'm an assistant professor at UMed in Austria, and I'm leading together with Professor Uwe Siebert this project, Targeted COVID-19 Vaccination Strategies, an agent-based modeling evaluation considering limited vaccination capacities. Before I start, I would like to thank the entire research team for their tremendous continuous support, team members from UMed, from DBH, and the Technical University of Vienna. Thanks also to the Gordon and Betty Moore Foundation and the Society for Medical Decision Making. And I would like to thank our standing policy and expert panel that we involved from the very first beginning in the project, where we joined leading decision makers from 4 decision making and policy advisory bodies in Austria, as well as clinical experts and international modelers. We are all very excited about the promising results of BioNTech and Moderna, and further vaccines are in development. And the aim of our project that we actually stated 5 months ago is to inform decision makers now at an early stage on the optimal distribution of health and non-health outcomes of targeted COVID-19 vaccination strategies, accounting for limited vaccination capacities and adherence to support vaccination prioritization in combination with further containment measures in Austria. We applied an agent-based population model considering the Austrian population represented by about 8 million statistical representatives, taking into account their contact behavior, regionality, and COVID-19 specific transmission probabilities and disease parameters. To answer our first question, what effect does vaccination of different target groups have on different outcomes? We assumed an initially limited number of vaccinations. That means in the beginning, we were considering batches that would be available of first 200,000 vaccines, followed by 3 batches of 750,000. And we were considering 5 groups within our population. These are the elderly, the middle-aged, vulnerable, younger people, and healthcare workers. And now in the first step, within our model, we vaccinated 200,000 people. And after the vaccination, the spread of the disease in the population is monitored over 6 months. And the relative reduction compared to no vaccination is calculated based on death, hospitalization, intensive care unit, etc. Let us say, for example, that by vaccinating, and this is what we did, then we did this simulation exercise for all our subgroups, running it again and again, and evaluating the long-term outcomes on the entire population. And now let's say, for example, that by vaccinating the first 200,000 people in the elderly, we can achieve the largest relative reduction in death and hospitalization. But now the question arises, which group of people should receive the next 750,000 vaccinations. Therefore, we have now carried out a sequential optimization algorithm to gain the prioritization sequence, so that we were testing then again in this subgroup in addition to the 200,000, and identify the subgroup that in the end leads to the highest benefit for the entire population. We used hospitalization and death as optimization criteria. We have also simulated scenarios in which we give the first 200,000 doses a priori to healthcare workers. Now let's have a look at our preliminary results. What effect does vaccinating different target groups have on the different outcomes? And here are the results for a non-sterilizing vaccine. On the x-axis, you see the groups that we were considering. And on the y-axis, we show the relative reduction versus no vaccination. So these are not absolute numbers. And the blue bars, they represent deaths, the orange bars, hospitalization, and the yellow one, new confirmed. So for example, with vaccinating the elderly with 200,000 doses, we would already see a relative reduction in hospitalization of around about 5% for the entire population. In summary, which trade-offs do we now find when we look at our results? We found that if we want to minimize hospitalization and death, this leads to giving priority to elderly, followed by the vulnerable people. If instead, for example, we start vaccinating middle-aged people, we would lose benefits in terms of death and hospitalization that could be avoided otherwise. So this is the delta when you compare the blue bars and the orange bars. We also considered healthcare workers, and we see that vaccination of healthcare workers compared to the elderly and vulnerable leads to much smaller relative reduction in hospitalization and death. But the negative effect of COVID-19 related healthcare workers' absenteeism on the endpoints presented here were not considered in our model. And protecting healthcare workers may also be critical to prevent a quality loss or even collapse of the healthcare system. There are other ethical principles other than just maximizing the benefits that may give high priority to frontline healthcare workers, such as occupational safety, that were not considered in the model, but that need to be considered in the discussion and when we deal with the work with the data and with the results. And as a final word, these results assume that the other protective measures against the spread of SARS-CoV-2 are maintained.
Thank you, Beata. That was also very interesting. And I want to encourage those who are listening to type in questions into the question and answer function. We will be using those as we discuss what you've heard and other questions you may have for our panel. Next up is Nilanjan Chatterjee. If you could get your slides shared and tell us about your work that's related to helping inform how vaccine distribution strategies and other public health strategies may all work together. I think we need you off mute.
Thank you, Kathy, for inviting me. That's a really great pleasure. Today, I'm going to talk about some work which we have done to assess individual and community level risk for COVID-19 mortality in the US. And I'll just talk about the implications for vaccine distributions. And I'm going to start by thanking all my collaborators, which is across Johns Hopkins University of Maryland, and a policy map insurance with which we work to produce interactive maps. The paper is going to be has been accepted provisionally in HR medicine, so we hope it'll come out soon. So we have tried to build what we consider a general population model for predicting risk for COVID-19 mortality. What I mean by that is the general population model is this model is applicable to individuals who are at the general population. That means they're currently healthy. So these models actually accounts for risk factors associated with both infections as well as complications after infection. So it is modeling from being healthy to the total process of mortality. And we believe that this kind of model can be help to bring equitable distribution of vaccines, because it can account for all kinds of factors, which we'll talk about in a moment, the both individual level risk factors as well as community level risks. And there are, other than vaccine distributions, it has a number of other preventive applications, which I will skip for the time being. So this is the two main sources of the data based on which the model was built. I think one of the largest population-based cohorts that are available for identifying risk factors for COVID-19 mortality and hospitalization is the UK Open Safely study, which is a cohort of 17 million individuals, which has experienced more than 10,000 deaths. And they have reported risk of mortality associated with the various factors, including age, gender, and race, 12 different health conditions, and measures of social deprivation. And then we adapted that model to account for actually US-specific factors. We took data from published by the Center for Disease Control US, CDC. It publishes the data of the mortality rate by age and race as ethnicity categories across 51 US states. So we took that data and we combined that information with the UK Open Safely study to make it more US-specific. I'm not going to too much talk about the detail, but those are the two main sources of data. So how does the model work? So we have a web-based risk calculator where people can go in, an individual, and they can start putting in information on various socio-demographic factors. So for example, in this case, this person is a male, 75 years old, Hispanic, and also lives in this particular state, California, and this particular county. And we use the county information to map to a social deprivation index variable that is available for US. And a number of disease conditions, like for example, this person is diabetic. And then based on that, we calculate a risk score for that individual and compare that with an average value of the risk score for the whole US population that we estimate based on National Health Survey. And from that, we estimate that person is at very high risk, is about 16-fold risk compared to the US average risk. And we categorize this person to be a very high risk person. And then we combine that information further with the community level pandemic dynamics information that we can get from various forecasting models. And we are particularly using this ensemble model that is published available at the CDC to produce an absolute rate of mortality for persons like that. So for example, for this person who is at this level of relative risk, we say that person's absolute rate of mortality is 86 per 100,000. During a particular specified period of time. So this was done in August, but we can do it in a future time frame based on the pandemic scenario models available. So now we took this model and then applied to the National Health Interview Survey datasets, which if you are not familiar with is a national level survey datasets. And then we asked the question that based on, and all of the factor informations are mostly available in these datasets, that how many people will identify in the US at these various levels of risk, which is like greater than 10-fold, 5 to 10-fold, 2 to 5-fold, and 1.2 to 2-fold, and then less than 1.2. And compared to the US average risk. And this is the estimates of the proportion of populations we believe that we can identify based on this model at this level of risk. And this is the actual number of individuals. And on this side, I'm showing is the proportion of death we expect to happen among these people, proportion of death from the total population. So for example, the first number you see, like if we target the vaccine to this 1.6% of the population, which is about 5 million, little less than 5 million, we expect to save, and suppose it's 100%, the vaccine is 100% efficacy, then we expect to save almost 28% of the death. And similarly, let's say if you go down, so let's say vaccinating the top about 10% of the population, we can almost save about 70% of the death based on these risk calculations. And by the time we vaccinate the top 20% of the population, which is about 50 million people, we can almost prevent 80% of the death according to this model. And then what we have done is that we took this model and we have applied to various national databases that has information on prevalence of some of these risk factors at the city levels, as well as county levels for the Medicare populations from the Medicare datasets. And we have worked with this insurance policy map company to develop a map, interactive maps where policymakers can go and look at in their cities as well as in their counties, how many individuals are there at these various levels of risk, which we categorize in for the based on the risk calculator. So I'll not, for the interest of time, I'm not going to go through that, but we hope that this kind of calculation will be very useful for local policymakers to decide how much vaccine resources that would be needed at the city level as well as county level and state levels. And this is where we are hosting some of the tools. You can look at the COVID-19risktools.com. And then this is my final slides about, and this is about the trade-off. So I do think this kind of modeling approach, formal modeling approach, that can incorporate information on various types of factors, like age and pre-existing conditions, various socio-demographic conditions, including ethnicity and race, as well as social deprivation that we have incorporated, and local pandemic dynamics, that could be all put in one umbrella, to produce this number based on which we can, and these characteristics are appropriately weighted based on the risk and not just in an ad hoc way. And so this is one of the advantage of this kind of modeling approach. But on the flip side, again, the trade-off side, I would say that there are a lot of other considerations to consider, because the risk, as in the previous presentation, it was mentioned that we may have to consider other factors than other than individual's own risk, which is the overall societal goods, such as by vaccinating people of frontline workers, individuals of national security importance, as well as risk of infection to others. And we have to also consider logistical challenges and infrastructure available. So I think there is the National Academy of Science and Medicine report has laid out a nice set of principles by which we want to distribute vaccine. And they have come up with some qualitative, I would say, simple categories for vaccination in 4 phases. But I think we still, this is not final, and this can be refined because, for example, they have not although they recognize the importance of the high risk for the socially deprived regions as well as African Americans and Hispanic populations, that has not been explicitly incorporated into these categories so far. So I think in the overall, we need simple categorizations because of they are simpler, but we do need to evaluate risk. And so that these categories are actually risk compatible, and it's only then we'll save most life with a certain amount of resources. So with that, I will conclude. Thank you.
And Litan, thank you very much. This gives a more finely tuned grain to thinking about risk, and I would encourage folks to go ahead and maybe you could put in the chat box too the links to the map of the full nation in the US. We will now hear from Uwe Seibert, who is involved in the study that Beata presented, but is also as a decision modeling expert who works directly with decision makers around the globe. We're going to have Uwe talk to us a little bit about what he just heard, some of his reflections. So go ahead, Uwe, if you'd like to share what you are thinking, having heard from those 3 presentations about work that's ongoing and very timely.
Thank you so much, Kathy. And first of all, thanks to presenters and the research teams you're working with, which are on your slides and working with you. And I know there are many people working in these teams, professors, senior scientists, and PhD students and others who are now perhaps doing the most relevant work of their life from the home office. So thank you all for that. And also thank you for giving me the opportunity to react to this fantastic work and presentations on these extremely important topics. Being a physician by training and a health decision scientist in my last at least 2 decades, I consider it a huge honor to share with you my probably very likely and likely subjective comments as a disclaimer. My first reaction to all three projects is that it is incredible how you achieve to incorporate real decision questions that must be answered now, or maybe even yesterday, and decision makers in your project. So these results will be heard. And I know some of them are on the desks of the departments and ministries of health of different countries already. My first reaction, I would call it interdisciplinarity. When we looked at the titles of the presenters, but also their teams, we saw presentations from different perspectives and disciplines coming from medicine, public health, health science, industrial engineering, complex systems, companies generating evidence. So I think this is the way to go, and congrats for having achieved that already. And there's probably a long list that will be included in the future. My second, that's a bit longer one, is on, I would call it on orchestras. So that at least two types of orchestras. The one is the orchestra of interventions. So we have medicines, we have non-pharmaceutical interventions, NPIs, vaccination, psychosocial assistance, economic help, which is not in health, but in economics. So Dr. Sean's research joined vaccination with NPIs. So this reminded me of, former public health problems. Should we vaccinate against HPV, human papillomavirus, or should we do more screening for that? Like, it's not an and or question. We can do both. The answer or the question is, how do we combine the one with the other? And keeping in mind, and I think this is very important to go forward, is that each of these different interventions, which Dr. Liu showed on one of the slides, has different variants. So if I remember correctly, there were like 4 social distancing variants to do, combined with 5 different school closing quarantines and so on. So making a quick calculation and combining that with different vaccine options, this would give us hundreds of different options to do. And one principle in health decision science is not to miss any of these possible ideal options to truly optimize. So this shows that we have a lot of work in front of us, and that takes probably a more holistic look that we all can do until now. So this leads me to the second type of orchestra. We probably need not just 5 or 10 or 20 people working on a team, but likely hundreds. I do not like comparisons with war, but this one I think is appropriate. We're in a war against the virus, and we need to, we need an army of public health fighters in the research and in the actions. And as this is a global war, all these public health fighters from all countries should march together. Of course, we need to bring all these decisions down to the local level, and the last presentation showed this very nicely, how things may depend on geography and individuals, and it always works best in a decentralized way. Delivering a vaccine in Seattle will probably be different than in the Amazon area of Brazil or in a small village in the Austrian mountains. So am I optimistic on that global marching together? Unfortunately, I have to say no. We have academic societies such as the Society for Medical Decision Making and others, and we need those more than ever in these days. And hopefully WHO and other programs such as COVAX and others can take a role to coordinate the next urgent research and actions. And we all must stand together with us and put behind our self-pride and self-interest to win this war. But it needs much more than the current picture we see globally is letting us expect. So I hope my pessimism can change one day to optimism here. Let me say a little bit about some technical things, modeling and model types. So Dr. Liu and Dr. Yan, they use agent-based models. So more and more we see these models coming up, and they are definitely needed and helpful when we model interactions, which is the case here. Cohort models, the other type of models, still may help us making overall national predictions. These models may be simpler, having less assumptions behind them, and they may work on the overall average for a country. So the purpose of the research will continue to drive model choice, which was very nicely shown here. Then we know these sayings that models are as good or as bad as their inputs. garbage in, garbage out, or valid data in, valid results out. So I found it very important to see that one of these input parameters, which is the risk of outcomes, was presented by Dr. Chatterjee in detail. So it's the most important parameter that we plug into our models in order to minimize morbidity in the elderly and in the vulnerable. So it shows that, you know, these groups, they must work together. Maybe the single models, they don't have these, you know, detailed scores or prediction functions that come from the other project. Now that other project did the functions, but not the modeling. So this is an important way, and it's great to sit in a panel where you see both things at the same time. A quick reaction on uncertainty, and I won't go deep here. It's that all that's, you know, mentioned limitations and uncertainty. So I just want to remind that modeling is capable of analyzing the uncertainty itself. Uncertainty is not something nice, but decision analysis and modeling gives us the way to look at that. What I also thought that the information to the public came across. So we had models informing decision makers, but evidence can stand for itself or for the public. So it may help in the planning for the decision makers, but as we have seen from the last presentation, everybody can relate gender, race, or ethnicity, or diseases, and plug their own values in this individual interactive tool, and that works for people. So down the road, we may use these risk scores even for prioritization, but we have to be very transparent, because one of the ethical principles is you must treat equal people equally. So you need that basis to say what is equal. I want to close with a comment on trade-offs. So all presenters mentioned trade-off. None of them analyze them formally. So that's still a job to do. And if you look at the WHO document for ethics and COVID-19 resource allocation priority setting, you see everybody mentions these trade-offs. So people say, you know, it depends what you want. You want to save life, you do this. You vaccinate the elderly. If you want to save, if you want to protect the healthcare workers to, you know, stabilize the system, you have to vaccinate them first. But what is really the bottom point here is that decision making is usually a task with multiple objectives at the same time. So we have to meet the optimal balance between these goals, trade-offs, how you all mentioned it. So in a side sentence, Dr. Jan pointed out that the first rule in decision science, I would call, is you have multiple options. If you want to compare, you have to look at the deltas, the differences. They may be small compared to the huge wave of infections you see, but this is what we can change. When we make decisions, we have to focus on what we can change about these few percent of lives we can save. And then you compare these deltas to the delta of the other outcome, the negatives effect. So that's decision modeling. That's what we can calculate. Then we have to balance them, and that's tough. So we may have goals like saving lives or gaining qualities or reduce hospitalizations, but we may also have goals like protecting the vulnerable or protecting healthcare workers, teachers. So don't want to, you know, throw this in a lottery, but make some fair ethical choice here. We need a mix of different ethical principles. One would be utility maximization, so maximize the benefits. The other is equity. So we would like to make sure that, you know, maybe the vulnerable in the first place, even if we don't save all of their lives, should be prioritized because they're starting in a bad place anyway. And then we have the principle of deontology, the study of duties. So what should we do? And maybe we have the duty to protect our teachers, to protect our healthcare workers, because they don't have a choice. They cannot say, I stay home alone, but safe. They have to go out, and maybe it's a duty to give them the protection in this war. And let me call it the risk compensatory justice, to just take some ethical terms here. So they have to go and to be just. And that is part of, you know, fairness is one ethical principle, to give them the vaccines, even if that doesn't save all the lives that, for example, in the results we have seen from the modeling's outcomes are saved. So the tough questions nobody wants to ask, but we have to ask ourselves is, how many lives I'm willing to give up in order to protect the healthcare worker? or turn it around, maybe that sounds a bit better. How many risks for teachers am I willing to take to save one life? Daniel Polsky mentioned at the end of the last panel session that the risk of being first to receive vaccination is also a thing. I learned that from that talk. So it may be something that you want to be the first, you want to be prioritized, but it's also a risk. If you learn that there are side effects in clinical trials, we start trying new interventions on healthy people, and then we extend. So how much should we extend this principle to the public health implementation of a completely new substance being injected in billions of healthy bodies? So is that something, and I usually, and that is my last statement here, I usually said, when people say, let's do compromises, let's give a little bit here and a little bit there, something to the healthcare workers, something to the and so on. I usually said, no, then you're definitely not having the optimal choice. Pick the ones that give you most, and then if you have more vaccinations, more vaccine doses in place, go to the next place and the next. But I changed my mind because of that statement of Daniel Polsky. So we should at least, run this vaccination in parallel in a few different groups, so that we have the chance to learn, that everybody's participating in this human global experiment, and we can learn, and we would call that value of information analysis or value of information decision science, so that we can, at least after half a year, we can say, oh, here we made a mistake, but fortunately it's not so big because we tried that first. Thank you very much.
Thank you for those comments. You really covered quite a bit of important territory, and I appreciate that. I'm sure we'll get into more discussion as a result of your reflections and the next set. So Dan Gorenstein, if you could share your reactions to what you've heard so far. I think you're on mute.
Thanks everybody for having me. I appreciate this very much, to be here with all of you. And it is humbling to be on a panel with people whose work really is at the cutting edge and is ultimately the information, the data, the evidence that the decision makers around the world will use to figure out how to distribute these vaccines. These are
before you go on, Dan, you might want to get a little closer to your microphone. I know you're usually on radio broadcasting. But...
Okay, sure. Is that any better?
Yeah, you're a little louder. Thank you.
Okay, great. Sure. I think I really applaud the panel and you, Kathy, for helping design this information within the context of trade-offs. I think that many people, at least in the US, when they think about their healthcare system, they think that the healthcare system is something that can offer perfect solutions that have no downside. And I think every presenter today talked about that there is real downside, and we need to consider these downsides. And what excites me about this panel is that you have different people coming from different angles on this question of vaccine distribution, as well as other attempts. Sean, your work there in Seattle and King County, other interventions that can be used to keep us safe. And what I heard, and Uwe, I really loved your word orchestra. This whole panel, honestly, struck me as an orchestra where all of you are playing different instruments, and together there actually is a concert happening, right? Sean's information around how we should be thinking about mask use and school closures and other techniques. Nilanjan, your work around at a community level, where are the sort of hot spots in our country that really need use? Beta, these questions of sort of modeling out what happens when you give vaccine first to the elderly and the vulnerable. What are the potential downsides to this? You begin to put all these pieces together, and perhaps we begin to be able to make slightly better decisions. And so I guess look, I am no expert here. I am somebody who talks to experts and gets an opportunity to ask questions. And so I'll do what I do best, which is that. And I'm curious to ask you all, and perhaps maybe to go to you, Kathy, since you put this group of people together. Do you think it is possible, Kathy, to stitch together these pieces of information in a way that policymakers could then begin to make much more informed decisions on how to, let's just be honest about this, how to ration care?
Yeah, and how to ration almost or press up on the intensity or lower the intensity of public health interventions or choices within that. Yes, you know, it's a wonderful framing, Dan. Thank you for your comments, and also just this idea of how these different sources of analytically based insights can be stitched together. We'll move from music to sewing, it's a real challenge. Honestly, I think back to some work in the early days of trying to create the evidence that could not create, but basically be able to pull together the different evidence streams that could inform guidelines for care, and the beginning of evidence-based medicine. One of my colleagues in that talked about how if you have a guideline that's backed by really good evidence, that's been put together by those who understand how to combine different streams of evidence, then your guideline is evidence-based. And you don't need to look in the box. It's the intel inside the computer, or whatever chip is inside the computer, just running it. You don't need to look inside and know about it. And that's how a lot of this type of analysis is. If it's done very well, and we have a group that can kind of peer review each other and elevate what's done. As Uwe was saying, there's different kinds of models, different uses require different models. If this work is done well, then technically it's good, but how does it actually get into the decision maker's hands at the moment that it needs to get there? And how does it get put in those hands with other efforts that have created complementary information? And then is there a way to do the analysis in a way that combines all these streams? Well, each of these analyses take a lot of time to do well. And it's the building the plane while it's moving, all the analogies that are going on that way is really true. What we have with the vaccines coming is we have a little bit more lead time. The unfortunate part about this pandemic going on so long is that more lives are being affected and will continue to be affected. But the silver lining, I like to look for silver linings, is that it gives those who are, in the basement toiling away with these types of analyses and data streams that are also becoming more and more enhanced, more and more knowledge from the data, that's building, gives more time to do the kind of analyses that were just shown. So I would look to the four decision analysts who are very active in trying to understand parts of this, features of this pandemic, to react to your question, Dan, about how each of you thinks you might stitch together some of your work with some of the other work that you just heard, because that is the real challenge. How do we do that in real time with the vaccines hopefully coming very soon? And I know everyone here is really smart, works with decision makers, and knows how important it is to take the right amount of time, not too much time, not too little time, working on these analyses. So, maybe, I'd like to start with you, Nilanjan, because you're working on an ability to be able to be public facing, that individuals in the public can actually enter their values, not values as in their preferences, but their biologic information, and get out their risk and understand that, and then rolled up to the community level. This is really important work as we move into the vaccine era. But how does it get does it get layered in? I know you've had much experience with that through your work at the National Cancer Institute as well. So we'd like to hear your reaction, and then we'll kind of go around the panel room and hear everybody's reactions.
Yeah, I think I really like the term stitching evidence across different types of data. I mean, in fact, when we started building the model, the individual level model, I mean, one of our goal was to be able to at least partially do that. And I'll give an example, because I think, like, that we heard like agent-based model, a lot of forecasting models that have been very popular from the beginning of the pandemic. And I think they have become more and more sophisticated over time, to bring in a lot of different kind of intervention information, behavior information, but that make the projection at the population level. And then we have separate type of studies which has provided information on individual level risk factors, right? That is, like your ethnicity or your health, sort of your diabetes or age, all of that increasing the risk of hospitalization and the mortality. And so our model is actually, so we thought like, okay, we're not going to reinvent the wheel. We are not going to go develop another, forecasting model. We are going to take, what all people have done. There's this amazing work is going on. So we use the ensemble estimator that combines information across many different these forecasting models, and then combine that with these individual level risk factors, so that we can come up with estimates of risk that is, it combines both type of information. So it is really that stitching of the different type of information that is going on in our tool. Now, having said that, as I think you already pointed out, there are many challenges. For example, some of the things we cannot yet incorporate, let's say, so this is calculating an individual's own risk, but we are not, saying what is that person, how much risk that person can give to other persons, right? That is what the discussion comes when we're trying to prioritize people for frontline workers, because the reason we want to prioritize them because they give high risk of infection to others, right? So that's another type of information. And so I think bringing it all under the same umbrella, it is challenging. And we have been, I think, through our tool, we have been partially able to combine different type of information. But I really like to hear from other people, like, like how do you really weigh, like, for example, all the criteria the National Academy of Science and Medicine has come up, risk of individual infection, mortality, but also risk to others, and, the social national security. How do you weigh all of those things under one umbrella? And I find it challenging.
And I just want to jump in here for a quick second, Nilanjan. Of the research that was presented today, what is it that you would really like to add first to your model? And what would that be, and how difficult do you think that would be to do?
Right. So one of the things, I think it was mentioned that what we could incorporate is the occupation. We have not incorporated occupation, and we know that frontline occupation has high risk of infection. And I think that is, at least conceptually, I think we can do it with once we have the parameter, we can pull the parameters from published studies that, if you are a frontline worker, how much, what is the rate of infection you have compared to, other populations, right? And if once we get those parameters, it is relatively conceptually easy to incorporate, and that is the next thing we'll be doing. And yeah, so that's one of the things we would like to do in the short term.
And let me just follow up one final time here on this. If you got that information and then you could turn this information over to health officials at the federal level, as well as state and local officials, how would you try to frame the information that you are handing over to them? How would you try to help these people, these decision makers, think about the trade-offs in front of them?
Right. I mean, so one of the reasons I like risk model, in terms, because it comes, it weighs in all of these different factors, right? We are talking about age, we are talking about pre-existing conditions, we are talking about socio-demographic factors, we are talking about occupations, right? And what risk model tries to put them is that they try to weight those factors according to how much risk they contribute, and then bring down into one number, okay? And that one number you can think of as bringing equity, because it is incorporating all of the different factors we talked about, and it is weighing them according to their importance in contribution to certain outcome. Let's say I'm focusing on the overall mortality, okay? And so there is some, I think risk is a single number, which do help you to bring equity by bringing in a lot of different factors. But at the same time, I would also say, like, on the trade-off side, that, actually doing a risk calculation is logistically more difficult, right? If somebody says, okay, just go ahead and, vaccinate people who are 65 years or older, and then you do this category, these are kind of qualitative category. This is logistically simpler, right? So, but I do think whatever categories we come up with, I think for logistical purpose, we need to come up with simple prioritization categories. But I do think we need to evaluate the risk based on a risk model so that we can show that at least those priority categories are compatible with the risk. Otherwise, we are not going to save as much life as we could save.
And on that point, the idea of saving lives, whether it's directly through averting infections or other means, there's these optimization approaches that Beata and Sean and Uwe have worked on. I've been seeing you shake your head, Sean. So have you some thoughts in terms of the idea of what could be stitched together here, or what additional insights you have based on what you've heard since you went first?
Great. Thank you so much, Dan, for the question. And it's so exciting to see a variety of very interesting presentations today. So I would like to address this stitching different data together to inform the model. So one particular question our modeling group is extremely excited about is the combinations of behavioral data with disease parameters, as well as the contact network. That's really the underlying support for the model. So in the early days when we started back in March, so we used the best available evidence on epidemiology parameters and then the disease parameters. But we really don't know a lot about the behavioral aspects, such as compliance to face mask use, what kind of school closure or hybrid school we're going to have starting in September. So the mechanistic model that we have really has this advantage of simulating or testing different combinations of compliances. As time goes on, we recalibrated model. We have to update to the current local situation, how the lockdowns and the school closure really keep changing as time goes on through September and October. So these behavioral information we found out are actually in some ways driving the total infections and driving the outbreaks. So we really think that's the important questions to look at as vaccines starting to roll out early next year. Some new information really come out on the equity side, right? So we have these really good CDC data on social vulnerability index, as well as these newer COVID-19 based community vulnerability index. So now the question is, how do we use these information to really look at both of the socioeconomic aspect of equity as well as the spatial aspect of the equity? I think from the map I've shown today, we see there's definitely very different neighborhood. They have disparities, both in terms of disease burden and perhaps like the percentage of essential health workers that really needs to be prioritized. So with this model, I think our next big step is, again, combining the social vulnerability side with the behavioral side and keep updating also on the disease parameter side with newer treatment and the vaccine effectiveness as that involves. So now we can use all these updated data, especially I want to say like Professor Ilanji, your work on the risk-based factors, all these comorbidity data, we would love to use those to add to our current model.
And Sean, a follow-up here for you. Have you had any conversations with city or county officials, Seattle or King County officials? Are they aware of your research?
Yeah, that's a great question. Yes, so we're working with the King County Health Officer, Dr. Jeff Duchin, as well as the Washington Health Officer. So the plan is we're going to have a very concise report, as well as a presentation deck to communicate kind of like the aim 1 of our research. And aim 2, which is the vaccine rollout. So we're just kind of starting that research right now. So from the King County side and the Washington State side, so they have not put out their official vaccine allocation strategies out yet. But the plan right now is to kind of follow CDC guidelines as well as these National Academies guidelines. So in our model, we're going to compare outcomes from these guidelines as well as any update from the local health officials if with their I guess the newest plan for vaccine strategies tailored to King County. So that's definitely our next step.
And what information do they want from you? What questions are you getting from the state and the county officials? And how does that, based on the questions that they're asking, how does that make you think about how these public health officials are actually thinking about the trade-offs themselves?
Mm-hmm. Great question. I think equity is definitely a very important piece. So again, looking at the King County, Seattle region, we can see the disease burden is very different, right? South Seattle, we see much higher incidence and prevalence. So how to be, distribute vaccine in the most equitable way, and also building up, the rest of the health system factors, right? The contact tracing, as well as testing, right? To consider everything together, that's one really important question. So another question we're really excited about, I think, is in combination of these NPIs, right? Some of these low tech, we call it low tech, for example, mask wearing. So as vaccines being distributed and hopefully building up herd immunities in the future, how do we gradually reopen society in terms of tapering off these NPIs? In combination, I think would be a very exciting kind of insight from this type of modeling.
And one final quick question here, and this gets back a little bit to some of what Uwe talked about in his presentation. When you say folks are the folks in the state and the county are focused on equity, does that ultimately mean, within the context of trade-offs,
Yeah.
does equity mean that the acknowledgement that we are not just going to administer vaccine to the elderly and the most vulnerable? We are going to use other criteria to make sure other people get it. In other words, there will be some vulnerable people who will likely die as a result of the decision making we're going to do, because we're prioritizing things beyond just minimizing mortality.
Yeah, that's a really important question. I think the key is the trade-offs again, right? So there might be some competing objectives. If we want to minimize total infection, that may not result the same allocation strategy as minimizing, deaths, as well as equity considerations and economic considerations, right? So we definitely plan to have multi-objectives in our model to examine this particular trade-off. And besides, there's spatial considerations, right? Spatial equity is not the same as social equity. And so these are, I think, as long as we're very transparent about our objectives, I think these allocation strategies hopefully will be clearly communicated and with clear, as you say, the rationing goal, I think, is a very difficult thing for, health policymakers and general public to swallow. But I think these type of model really laid out the evidence.
Maybe moving to the European context, because sometimes in Europe, there's maybe a little bit more of a, I might be wrong, but a little bit more of an appetite for understanding rationing in maybe a different sense. So as Beata, as you think about your model and what you could draw in the stitching together, if you had any thoughts about that, please share that. But if you're also having any thoughts, in terms of this idea of, within your locale, how do you work with decision makers on these optimization ideas? What's happening there in your context?
Yeah, sure. I'm happy to share these insights, what we do or how we approach this here in Austria. And we are really in a luxury situation that we work closely together with the health authorities here and also with people involved in the, so working at the Ministry of Health. So we build up the entire project with this advisory panel, and we bring together these people, and we just this week we're presenting the results. And it really shows that when you sit together and you show your results and you digest things together, how valuable it is to understand the way people think about it, to understand all your parameters in your model. So this was crucial in the very beginning when we started to model it. Then the physicians came up like, and do you realize and make sure that you have a sterilizing and a non-sterilizing scenario? And also with respect to decision makers, because we put some of the outcome parameters that we wanted to have for our optimization exercise as the one to go, and the main was death. And then in the discussion, people brought up like, but we are also concerned about hospitalization. So you definitely have to have hospitalization. And in the beginning, we thought like, okay, we're going to have one optimization criteria and just show the outcome for the other criteria. But the results, of course, can differ when you have different optimization criteria. And so within our modeling exercise, we now have scenarios going with the one and with the other optimization criteria. And what we found now is, for example, for the sequence of the providing 2.5 million vaccines to the individuals, going with death or going with hospitalizations avoided, gives us the same results, gives us the same secrets going from the elderly to the vulnerable. But now, only that we evaluate it, we really know it, and we can show and discuss further. And with respect to what kind of next steps, well, we were actually asked, first of all, that when we have further results from the trials, because now we have included an effectiveness of 70%, and they said, like, we need to run this model, and we want to see your results when we have further effectiveness data. And another thing that Jean-Louis also touched on is the contact behavior. We have pretty good data from a study like the contact behavior, but this was in a period before COVID-19. So we included these parameters, and now in Germany and also in the UK, there is this big study, the Polymod study, going on and evaluating the changes in the behavior, since now vulnerable people may react, they may live their life differently. And this is something where we wait for the data, and we are happy to share this also. So maybe this could be helpful within your context, at least that we see, you know, the difference. It may not be the baseline that is the same, but the difference may be similar. And I think this would be extremely helpful. And another thing that we only in parts right now incorporated is the effect of the healthcare workers that they have, for example, when they are in the nursing homes. So we have direct links for the individual healthcare workers in the nursing homes. So we have there also they could infect the elderly in the nursing homes. But again, what we don't have is a specific behavior and context structure within this little cell, so to say. And the same for the hospitals. So this is the next thing to evaluate. And what we not often have the luxury, but what is extremely helpful is a cross-model validation. So this is what we did in other studies, for example, in oncology, where we had our model and we were evaluating breast cancer treatment, and a group in Canada and Toronto, they were evaluating similar questions, and then we ran our model against each other. And it gave us so much insight into our model. We understood our results and also the input data. So this would be extremely helpful. And another thing that also was asked in our last meeting with the expert was, okay, could we have the subgroups? And as you saw, we only modeled 5 subgroups, which is not a lot. But with respect to simulation time was the one to go for now in the beginning. But they said, okay, we should have it more granular, yeah, more details in. And I think here the work of Niranjan can fit in really, really good to identify, to say, okay, and this is now our subgroup, or the way how we define vulnerable. Right now, we only define vulnerable based on the increased risk of having a severe disease. So this would be our next steps.
Right. Well,
but maybe Uwe want to touch on this and extendable to.
Yeah, we're getting short on time, but so what I want to do is just reflect real quickly on the fact that we have just like scratched the surface of how this kind of thinking is going on and may not be completely well appreciated outside of the zones of strong activity. The work that hasn't been done as much is exposing this work between the decision modeling community and the decision-making community. So I would hope for further chances for this group and groups like this to get together and share amongst ourselves, but in a way like we've just done, where we have Dan Gorenstein asking us these kinds of questions that bring to the surface what the decision modeling community knows, but may not actually be sharing because we're busy sharing the details of how we do our models instead of the details of how we take this work and weave it together and have an impact with decision makers. And Uwe, thank you for your comments that really, gave the full picture also. So we'll break here. Knowing that our time is up, and for the live streaming too, I understand it cuts off straight at the 11:30, so I don't want us cutting off. I don't want us cut off by something besides ourselves. Thank you all for your time today, your fascinating work, the way you think. We really will benefit from this, I'm quite sure, worldwide. It's been nice to have the entire group presenting from very local context to national context to international contexts. So continue on. As I said at the beginning, I know you're on the front lines too. I know people are working around the clock in this way. Each one of you is, along with your big teams, and thank you. Thank you for all the work you do.
Thank you.
Thank you very much.
Thank you.
We end here, I think.